Well, welcome everyone to the Special Populations Core 2023 seminar series of the New Jersey Alliance for Clinical and Translational Science. Thanks for joining us for today's presentation. We're very excited to have Dr. Liz Suarez with us to discuss treatments for opioid use disorder in pregnancy, focusing on the evidence for the safety of pharmacologic treatments. Before we jump in, if you have any clarifying questions during the talk, please feel free to unmute and ask during the presentation. Any more in-depth questions or questions added to the chat, we'll get to during the Q&A following the talk. To get us started, I'm going to turn it over to the Director of the Center for Health Services Research here at Rutgers and lead of the NJAC Special Populations Core, Dr. Stephen Crystal, to introduce Dr. Suarez. So Dr. Crystal, over to you.
We're very delighted to introduce Elizabeth Suarez, who has joined PETS as a pharmacoepidemiologist focused on studying the use and safety of medications in pregnancy. She received her PhD in epidemiology from UNC at Chapel Hill, one of the top programs, MPH in epidemiology from Boston University. She then held a postdoc with the Sentinel Operations Center at the Department of Population Medicine at Harvard Pilgrim, where they have access to all the nation's drug data, just about. And Harvard Medical School, she contributed to projects on the use of tree-based scan statistics for surveillance of medication use during pregnancy by the Sentinel Initiative. Did a second postdoc fellowship with the Division of Pharmacoepi and Pharmacoeconomics at Brigham and Women's Hospital and Harvard Medical School. She worked with the Harvard program of perinatal and pediatric pharmacoepidemiology, also working with many old friends of the Institute on studies of medication safety in pregnancy using Medicaid and private insurance data. Her research is focused on novel methods for studying medication safety in pregnancy using healthcare utilization data, including both insurance claims and electronic health records. Her recent research has involved the safety of antidepressants, other psychotropic medications, and medications for opioid use disorder in pregnancy. So we're delighted to have the opportunity to hear from Liz. Thank you.
Thanks so much. Thanks for having me. As has been stated, I'm going to talk today about treating pregnant patients with opioid use disorder. This topic could be huge. There's lots of elements about how we treat pregnant patients with opioid use disorder. The thing I'm going to focus mostly is on the safety of the medications that are used in this population. And so I have nothing to disclose. And as Steve mentioned at the beginning in my intro, I was a postdoc at Brigham and Women's Hospital and Harvard Medical School before joining Rutgers last September. So this work is what I had done and actually continue to do with that group at Harvard. So I wanted to make sure to give them a shout out as well. Okay, so opioid use disorder in pregnancy. I'm going to give you a little background. I'll get to the paper specifically that I want to talk about and also talk through some other papers that I have in the works, at least one that's about to be published on this population in the Medicaid population. So opioid use disorder, or OUD, is associated with risk to the pregnant person and the fetus, both through the obvious effects of opioid misuse, so sustained opioid exposure, the risk of overdose, the risk of withdrawal. And then there's also factors associated with the opioid use disorder, which is associated with a lack of prenatal care, associated with a high level of smoking and other substance use continued through pregnancy. And there's other lifestyle factors and increased risk for infections that we'd be concerned about. So we know there's a benefit of treatment, but we also know that the majority of reproductive age and pregnant people are not receiving this treatment. So one recent publication estimated that about 75% of women of reproductive age in the US are untreated, and this continues to 65% during pregnancy. So a little bit better in pregnancy, but still really not great statistics there. So this slide just kind of gives you a background on some national data on the prevalence of opioid use disorder in pregnancy. This is from delivery, hospitalization, discharge records in the National Inpatient Sample and state inpatient databases. I also kind of pulled out in this figure here to the right New Jersey data just for a local comparison. And so it affects in the US about 8.2 per thousand deliveries, a little bit lower than the national average in New Jersey, predominantly in non-Hispanic white patients and disproportionately affecting patients that are insured by Medicaid. This probably, however, is an underestimate. There's imperfect sensitivity of capturing OUD just in discharge records. So National Survey of Drug Use and Health estimated that 1.4% of pregnant women report past month opioid use, which is a bit higher than this 0.8% from the National Inpatient Survey. So we know that untreated patients are at a greater risk of overdose and use of other substances during pregnancy. The evidence on the risk of continued opioid exposure in pregnancy for the fetus is mixed still, unfortunately. We know there's an increased risk of neonatal abstinence syndrome, which is that withdrawal the infant goes through at birth, which results in a longer hospital stay, requirement of treatment of that infant after delivery. There's also potential for increased risk of preterm birth and low birth weight in these infants. And the evidence is really mixed on whether the risk of malformations is increased with continued opioid exposure. A lot of the studies on this area are actually restricted to or look more closely at regular prescription opioid use for pain treatment in pregnancy and not so much on this continued misuse of opioids during pregnancy. Of course, we know there is a risk of overdose with active opioid misuse during pregnancy and at any time. And so this is just some background information from a cohort in Massachusetts. I believe this is all patients in Massachusetts collected from multiple databases that had evidence of opioid use disorder in the year prior to their live birth delivery. And so we see that this is both fatal and non-fatal overdose events. The risk goes down in second and third trimester and then is highest in this late postpartum period. And then if we stratify by whether or not these patients are currently on pharmacotherapy for their opioid use disorder, we see that this risk is quite a bit lower in the orange than in the gray for those on treatment versus not. With the exception of maybe third trimester. Not quite sure what was happening there, but overall we see outside of pregnancy, obviously, and also in pregnancy, we see a benefit of having these patients on treatment. So related to that, opioid use disorder has become a really important contributor to pregnancy-associated death. So by pregnancy-associated death, I mean deaths that occur during pregnancy, at delivery, or often defined as the 1 year following delivery, so that first year postpartum. And in the United States from 2007 to 2016, the pregnancy-associated mortality ratio that was opioid related increased from 1.3 to 4.2 per 100,000 live births. So this is increasing over time. And about 10% of pregnancy-associated deaths were due to opioid exposure. So this looks a little bit different. I pulled out the most recent data from New Jersey, and we can see that it seems as if in New Jersey, our pregnancy-associated deaths associated to substance use disorder is 34%. So a bit higher compared to what we expect for all substances in pregnancy of 13, 16%. Higher than the national average. And of those deaths that are pregnancy associated but not related, so this means these deaths are surrounding pregnancy, but they're not judged to be directly related to the pregnancy, more than half of those are related to substance use disorder. So this is clearly an issue that needs to be addressed, and we need to be getting these patients into treatment to help them avoid these really dire consequences. So this is some other data, not published yet, it's in press, that also kind of highlights this dangerous period for these patients who have diagnosed opioid use disorder in this postpartum period. So The data I'm going to be showing you in a bit about the safety of medications is from Medicaid data. This is also from Medicaid data, and this is specifically from the cohort of Medicaid data that's linked to the National Death Index. So we could classify some causes of death in this population in that postpartum year after they give birth. And we can see in the pink here is the pregnant individual's opioid use disorder. In the blue is just the full population of pregnant individuals, which was about 4.9 million in this Medicaid cohort between 2006 and 2013. And we can see across the board of all of these different, still somewhat broad categories of death, that these patients with documented opioid use disorder, so they have a diagnosis of opioid use disorder in their record during pregnancy, are at a greater risk of all different causes of death, and overall 6 times the incidence of death in this postpartum window. So these patients are particularly vulnerable. We did also in this paper, which will be out soon in obstetrics and gynecology, show that use of opioid medications for opioid use disorder, so the pharmacotherapy for opioid use disorder, did result in a decrease odds of overdose death and then also non-overdose death. So these weren't, these are really descriptive results. These weren't adjusted for a large range of confounders, but it gives you kind of that same message of these medications being overall beneficial for this population in terms of preventing these really dire outcomes. So when I'm talking about what these treatments are for opioid use disorder in pregnancy, I mean buprenorphine and methadone. So methadone, I'll start at the bottom of the table, is a agonist, and it's been available the longest and is traditionally the longest used and most widely used treatment for opioid use disorder. And that was traditionally true in pregnancy as well. So this was the drug that was originally recommended for use in pregnancy. And so methadone is administered through visits to an opioid treatment program. And while this is kind of changing with policies over time, patients really don't get take-home doses. They go to their opioid treatment program on probably a daily basis to receive their dose of methadone. Buprenorphine and also the combination drug buprenorphine naloxone have increased in pregnancy a lot over the last 10 plus years. So buprenorphine monotherapy was traditionally more commonly used, and actually I think still is more commonly used in pregnancy because we were unsure about the safety of naloxone. But that's also changing as well, because we do have some data now that suggests that buprenorphine naloxone may actually have a lower risk of neonatal abstinence syndrome and these other adverse outcomes, or no different from the other drugs. So from this Medicaid cohort, I'm going to talk about a little bit more. We have some data coming out specifically about buprenorphine naloxone, but overall, it seems like this is also going to probably sometime soon be a recommended treatment in pregnancy as well, because it has this added benefit of decreasing this risk of misuse and diversion due to the addition of naloxone. So these treatments are administered a little bit different than methadone. So buprenorphine can be given, it was up until very recently, I think January 2023, that buprenorphine had to be administered by a waivered provider. So they had to be approved and had a maximum number of patients that they could prescribe buprenorphine to. Now they just, I think, have to have DEA registration. So this potentially should open up the availability of buprenorphine to pregnant and non-pregnant patients. But during the time period when all this research has been done, it was more restricted, only being prescribed in an office setting by waivered providers. But then self-administered. So it's a kind of a 2-week, maybe 30-day prescription that patients get and they administer on a daily basis on their own. So the difference in administration between these two drugs and how they've historically been used tends to mean that patients in methadone, especially on pregnancy, may be considered to have more severe opioid use disorder. Patients who are recommended for buprenorphine are acknowledged to be able to self-administer the drug and take a little bit more control of their treatment and not require them to go to a methadone clinic every day for treatment. But whether a patient gets buprenorphine and methadone in pregnancy, and likely and definitely in general, even outside of pregnancy, also depends on the availability. So is there an opioid treatment center? Is there a waiver provider that's available to take them on as a patient? So there's a lot of factors that impact which of these two medications a patient is going to get, both in and out of pregnancy. So the MOTHER trial was published in 2010. And so this was kind of the first larger trial. I think there were some smaller ones that happened before this that specifically wanted to compare buprenorphine to methadone in pregnancy. And so they specifically looked at buprenorphine monotherapy without naloxone. And they looked at opioid-dependent pregnant patients from 18 to 41 years across 8 international sites. And these patients could either already be on treatment requesting a change, or they could be initiating treatment for the first time during pregnancy, so between the gestational weeks of 6 and 30. So what this trial found essentially was a significantly decreased amount of morphine needed to treat infants with neonatal abstinence syndrome, and a shorter hospital stay for those infants, for the infants that were treated with buprenorphine compared to methadone. So the buprenorphine group only had 58 patients. The methadone group had 73. So we're still talking about a pretty small trial here. Some of the secondary neonatal outcomes that this trial looked at: duration of treatment for NAS, and then also weight at birth, length at birth, and preterm birth status. And so while I think these results are suggestive of a benefit of buprenorphine, they didn't reach the trial's significance threshold. And then finally, the trial also looked at some maternal outcomes. So cesarean section, weight gain, complications at delivery, and didn't report any real differences across these outcomes for the mothers. So essentially, what the conclusions were is that these findings were consistent with the use of buprenorphine as an alternative to methadone for treatment of opioid dependency during pregnancy, because at this time of the trial, methadone was kind of the standard of care in pregnancy. So this is trying to establish at least that buprenorphine can be used in addition to methadone as a second option to methadone. They went further to say that the benefits of buprenorphine in reducing the severity of neonatal abstinence syndrome suggest that it should be considered a first-line treatment option in pregnancy. So this did change practice, but there was a lot of limitations. One was that small sample size. And then the second was that there was a really large differential dropout due to dissatisfaction with the treatment. So 20 of the patients in the buprenorphine group dropped out, compared to only 2 for the specific reason of being dissatisfied with the treatment. So that potentially could be biasing our results.
Liz, did they report on the dosing of buprenorphine in that period? Was it perhaps underdosed?
I believe the paper has more information on what the dosing was. And I think that, so the lead investigator on this trial, Henry Jones, was also a co-author on the paper I'm going to discuss from Medicaid paper. And, and she has suggested that that was, that I think at least now we understand more about how buprenorphine should be dosed in pregnancy than we did at the time of the trial. Yeah. I don't know what she would say about the implications, and I don't remember specifically what the paper states about dosing.
Yeah, great. Thank you.
Yep.
Because it certainly is a little bit of a puzzle.
Yeah, yeah. Okay. So clearly I forgot to put my animation here so you could actually see the data in this table. But I only wanted to make a point here is that there's been some other observational data on these outcomes since the trial. There's been, you can see the sample sizes here. This was Massachusetts Medicaid data with about 500 patients in each group. There was a single center in Pennsylvania that had a couple hundred per group, and then a population-based study in British Columbia that had a predominance of methadone use. And while you can see that there is kind of a lower risk for preterm birth, same found here in this Canadian study, but the overwhelming concern, and especially of these first two papers in the US, was that the benefit that we're seeing from buprenorphine is due to channeling of patients with less severe opioid use disorder to buprenorphine instead of methadone. So there really was a discussion in these papers and some subsequent papers about how we're not sure if we can really believe these results, because the patients that we send to buprenorphine treatment instead of methadone treatment are going to possibly just be healthier. So maybe that's why their infants end up having better outcomes. So that was one of the things that we were also concerned about addressing in any way that we could as we undertook a new observational study in this area. So this is the paper that I'm going to talk about for the rest of this talk. So this was published last December in New England Journal of Medicine, where we used Medicaid data nationwide, so Max and TAF data, to do a retrospective cohort study to look at buprenorphine and methadone use in pregnancy. And so this ended up being the largest population of these patients treated that's been published to date, significantly larger than the papers that had been out there previously, which I think was a huge benefit because it's hard to gather patient populations of a large size for this type of treatment. So I think most people probably are familiar with Medicaid data, but one of the reasons we like to use it in pregnancy is that it does cover about 40 to 50% of pregnancies in the US. Medicaid data, of course, includes some demographic characteristics, diagnoses and procedures received during inpatient, outpatient, and emergency visits, prescription medications dispensed in an outpatient setting as well. And so what we can capture from Medicaid data is buprenorphine and methadone treatment that is reimbursed by Medicaid. And our cohort included pregnancies that are linked to live-born infants. So we're only including live births here because we identify the pregnancy based on the delivery event. And then of course we want to link to live-born infants to be able to look at those neonatal outcomes in the first 30 to 90 days after delivery. So the pregnant individuals had to be enrolled from 90 days prior to their estimated last menstrual period or the estimated start of pregnancy through 30 days after delivery. And then the infants had to be enrolled for 3 months after delivery unless they died sooner during that period. So we're requiring this enrollment, especially for the pregnant individuals prior to pregnancy, because we want to be able to ascertain some covariates and other chronic health conditions that may be happening prior to their pregnancy start. So we're capturing buprenorphine through outpatient dispensings for either the monotherapy or the buprenorphine naloxone combination therapy. In this analysis, we didn't differentiate between the two. It's just any buprenorphine with either of these two dispensings. So of course, this is dispensing data, so we don't know if it was consumed, only paid for at a pharmacy. This differs from methadone, which we're picking up with administration codes based on administration of methadone in approved clinics. So we have procedure codes for this. And then we're looking specifically for evidence of these treatments during a window in early pregnancy, so roughly the first half, a window in late pregnancy, roughly the second half, ending at whenever their delivery occurred. And then also looking in a 30-day window prior to their delivery date, which is what we're interested in for the outcome of neonatal abstinence syndrome. The outcomes that we're interested in looking at here, of course, this is claims, so we're defining these based on diagnosis of procedure codes for conditions that are treated in healthcare settings. A lot of these outcomes are being picked up in the delivery hospitalization in our setting. We used algorithms with high positive predictive value to have less bias in our relative risk estimates when we could. And so specifically, we're looking at neonatal abstinence syndrome. We're not able to look at duration of treatment. We didn't feel quite comfortable looking at duration of hospital stay. So this is really just evidence of a diagnosis for neonatal abstinence syndrome in the infant record. We're also looking for small for gestational age, diagnoses, low birth weight, and preterm birth. And then for maternal outcomes, we looked at whether or not they had a cesarean delivery, and if they had this composite of severe maternal complications that are associated with maternal mortality. So this would be sepsis, preeclampsia, other really intense conditions that are happening to the mother around delivery. So we use propensity score overlap weighting to control for confounding, which weights the population with overlapping propensity for treatment with buprenorphine or methadone. So it's kind of the group in the middle of the distribution that had propensity for either buprenorphine or methadone. The covariates that we included some demographics. We do have race data in Medicaid. We can't directly measure OUD history and severity in claims data. So we have kind of proxies or markers of this. So we can see if they were already receiving this through Medicaid prior to their pregnancy start. We looked at ED and inpatient visits related to opioid use. We also looked at diagnosis for other non-opioid use, substance use independence. We looked at medical conditions associated with opioid use disorder, such as infections. This population also has a high burden of mental health conditions and chronic comorbid conditions, so those were also documented in detail. We looked at their other outpatient prescription medication use, their healthcare utilization, so number of ED visits, number of hospitalizations. Also, this included an index of their prenatal care utilization. And then we also did county level proxies for SES. So we use the zip code data in Medicaid to kind of understand the proportion of the area that these patients lived in that had, high rates of poverty, high rates of low education, and homelessness. Those were the three proxies that we used. So imperfect, but hopefully what we're capturing here is a wide range of proxies for comorbid conditions and severity of opioid use disorder that's happening in these patients to try to capture that potential confounding by severity that other papers have been really concerned about. We also did a high dimensional propensity score, which is commonly also done in these claims databases, where we are empirically selecting variables from all the available diagnosis codes, procedure codes, and medication dispensings based on the strength of the association between these variables and which medication they got. And so the goal of this is a secondary approach for confounding control. This was done after also forcing all of those predefined variables that I just mentioned into the model, is to capture confounders beyond those that we could pre-specify and define as distinct variables to hopefully capture things that we are potentially missing. Okay, so characteristics of the patients. As I mentioned, this population is a lot bigger than what has been able to be measured before. We were able to find about 10,000 buprenorphine patients and 4,300 methadone patients. So that's a big improvement over previous studies. Some things I will highlight. The buprenorphine patients were a little bit more likely to be white than the methadone patients. I think this also has a lot to do with the availability and geographic location where these treatments predominate. The buprenorphine patients had more reported other substance use or abuse issues. They also had, buprenorphine patients had either similar or greater reports of certain mental health conditions. And relatedly, they had greater utilization greater or similar utilization of lots of psychotropic medication. And one medication that did differ is that the methadone population had a greater prevalence of prescription opioids during pregnancy. The two groups were really similar in healthcare utilization. None of these standardized differences were greater than 10 if we're using that as our rough benchmark for balance. And then here is that prenatal care index that I mentioned. They're also really balanced on how adequate their prenatal care was judged to be based on what we can see in the Medicaid data. So overall, what we see here is that the buprenorphine patients actually do look like maybe a little bit worse than the methadone patients, but overall, a lot of these characteristics are relatively balanced. So a lot of these things are things, of course, that we are adjusting for in our propensity score models. So here are the infant outcomes. And so neonatal abstinence syndrome, preterm birth, small for gestational age, and low birth weight. You can see all of the results are grouped quite substantially on the side that favors buprenorphine. So we found that buprenorphine was associated with a lower risk of all of these conditions in infants compared to methadone. And we really didn't see much shift in our estimates once we did our traditional propensity score adjusted analysis, and then once we do our high dimensional propensity score analysis. So nothing that really fundamentally changed our conclusions. And this, for all these other infant outcomes, was consistent across whether they had exposure in early pregnancy or late pregnancy. But I will mention too that a lot of these patients had evidence of exposure across their entire pregnancy. So that result is not too surprising.
Liz, the previous results were from the propensity score matched population or just the unadjusted?
The previous result, meaning
the results that showed that the buprenorphine population seemed to have just as much morbidity. Was that from the matched population?
Here. This is from the full population.
From the full population, okay.
Yeah, so this is totally unweighted. So we're actually not matching. We're using propensity score weighting here.
Propensity score rating, yeah, okay.
Yeah,
that's very, very interesting in itself. And then so not surprisingly, then the propensity score adjustment didn't make much difference.
Yeah, it's really not surprising. And the high dimensional propensity score approach didn't pick up too much that really shifted things either.
Really interesting.
Yeah, so it was surprising to us that the patient groups did seem relatively similar, especially at this data spans from 2000 to 2018. So it's a really wide, varied period of these patients getting treatment, and also depending on what states are covering which treatments for their Medicaid program. So it was a little unsure what the characteristics were going to shake out to look like between these two groups. So I agree that was interesting to us as well. So the next set of outcomes here are the maternal outcomes. And we see this looks quite a bit different from the infant outcomes, where we really don't see much of a difference. So no difference in the use of cesarean section for delivery, and also, maybe a little bit favor buprenorphine for severe maternal complications, but really with the confidence intervals, not much you can say about whether or not there is a difference there. So overall, no real strong evidence that there's any difference in the maternal outcomes, which differs from what we saw for the infant outcomes. So as I kind of said before, the thought is this all just confounding? Is it really just because our methadone patients are more severe, and because we can't directly address this in claims data, we're just completely missing this huge amount of confounding that's accounting for this? So we think this is unlikely because we did adjust for as many proxies for severity as we thought we could capture in this data. So continued versus new treatment, inpatient and emergency room visits, other substance use and abuse. And as we just noted again, these really didn't look that different, or they definitely didn't look worse in the methadone group in our data. And also, I think it's notable that we saw results for infant outcomes, but not for the maternal. So I think if this was purely due to confounding, we would see a similar benefit in the maternal outcomes as well. We did do a couple of sensitivity analysis to interrogate some other areas that might be accounting for our results. So I'll show you the results for neonatal abstinence syndrome, and then I'll kind of flash a bigger result for some of the other outcomes. The result that's highlighted here is that main adjusted analysis. So just the propensity score adjusted analysis that I showed on the main results. So we were a little concerned because these drugs are administered in different ways. We have a lot of confidence that the methadone was actually consumed because they have to go to a clinic. for the administration of this medication. Buprenorphine, they could be given a prescription and we're not so sure it may be consumed. So one thing we did for the buprenorphine group is require that they had at least 2 dispensings during the specified window. And we saw that it makes no difference. Another thing a little less worried about, but another check of our data was that while we did restrict to formulations of buprenorphine and methadone and codes that were intended for treatment for opioid use disorder, not all of the patients actually had a diagnosis of opioid use disorder in their record. This was more true for buprenorphine than methadone. So if we restrict to a population that also had this documented, do we see any shift? And we do not. Medicaid coverage of buprenorphine and methadone changed a lot over our study period. A lot of states didn't cover at first either, and then maybe they covered one, but not the other. And so if incidence of our outcomes varies by state and year, this could introduce confounding. So we also did an analysis where we restricted the population to pregnancies that occurred during a time when their state covered both buprenorphine and methadone. And we see a tiny bit of a shift, but really same conclusions as before. And then this was an interesting analysis that we did about the potential for confounding. So we saw that the infants, or the pregnant individuals on methadone actually had more prescription medications and more recording of diagnoses than the methadone patients did, which kind of went against expectations that the methadone patients are particularly, or maybe worse off. One potential explanation for this is that this is claims data, and perhaps the act of getting buprenorphine through a waivered provider, such as maybe it's part of primary care, maybe it's part of prenatal care, might mean that these buprenorphine patients are getting more of their chronic conditions documented and treated with prescription medications than the methadone group. So maybe the methadone group really is more severe. We're just not recording it because they're not receiving as comprehensive of care. So the only way we could really think to assess this was to try to restrict to a population that we can assume had similar quality of care. And so we took that prenatal care utilization metric and restricted just to the highest level. So those were classified as having prenatal care starting at the appropriate time and having the appropriate number of visits throughout pregnancy. So we assume these patients have a similar quality of care. And we see that it really doesn't have any impact on our results. So the idea that we have kind of differential unmeasured confounding, maybe not so strong based on this analysis. And then you can see these are the other infant and then the maternal outcomes on the bottom for early and late exposure. And we kind of see the same story throughout, that while there's maybe a little bit of shifting, none of these sensitivity analyses changed our conclusions for any of the outcomes. So these results point to buprenorphine resulting in more favorable infant outcomes than methadone. And as I've kind of been talking through, it doesn't seem that bias is the primary driver of these results. And so I think the next interesting question here is why and what do we do about it? So there's been interest, especially from some physicians here at Rutgers, about does this change our practice, especially around this benefit for preterm birth is what they were particularly interested in that we see with buprenorphine and methadone compared to methadone. And so I think this really matters on why, because one potential theory is that methadone is incorrectly dosed in pregnancy. Having to go to the clinic and have a single daily dose maybe doesn't work in pregnancy. These patients need to be splitting up their dosing over the course of pregnancy. And so that's why we see adverse outcomes in the methadone group. Alternatively, it's that buprenorphine really does have less of an adverse impact on the fetus, maybe due to the difference of partial versus full agonists, but I think the mechanism here is really unclear. So these point to different changes in practice. So this changing in dosing, the pharmacokinetics of methadone in pregnancy means that having a single daily dose often leads to cycles of withdrawal. So a daily cycle of withdrawal in the patient, whereas if this patient were able to split their dosing, maybe one in the morning, one in the evening, however it makes sense, they might not be going through these mini cycles of withdrawal on a daily basis. So of course, because of how methadone is administered, this is mostly infeasible, maybe impossible for this to be done in the US right now because take-home doses are highly restricted. But we have some data showing that single daily dosing of methadone is associated with greater suppression of fetal neural behavior and movement compared to split dosing. But there really haven't been any studies that directly looked at infant outcomes in a split methadone dosing group compared to a single dosing group or compared to buprenorphine. So the biological possibility is there, but we don't have enough data to say for sure that this is what's causing the worst outcomes in methadone.
What's the thought with potentially lower risk of NAS with single daily dosing?
So that comes from one study that didn't have a comparison group. So they had they did like a small, it's not a trial because they didn't have a comparison group and there was no randomization, but they did kind of a pilot of split dosing and then compared it to national or state data on risk of neonatal abstinence syndrome. So there's some evidence, but it's not very robust, and I think this was probably something like 30 patients. So that's why I have potentially lower risk of neonatal abstinence syndrome in there. So I think it goes along with the same, notes in the last bullet point that we really don't have well-designed studies testing this as an intervention.
What about the clearance time for buprenorphine versus for the infant for buprenorphine versus methadone after the birth? I mean, the normal protocol, the moms would remain on treatment right up until the birth.
Yeah, as far as I know.
So then is there a longer clearance time for the methadone for the infant?
I really don't know. That's a good question.
Maybe some of our clinical colleagues have insight on that.
Yeah, anyone else can feel free to jump in. I'll just keep going on to this. I don't think I only have like 2 more slides, and then we can open it up to a more broader discussion. But this is kind of the other alternative. If it really is that buprenorphine is better, the question is, should we be switching patients from buprenorphine to methadone? So this is not recommended currently because doing this switch can result in withdrawal because the buprenorphine patients have to be, or the patients that are on methadone, they have to be off their methadone for a certain amount of time before they're able to initiate the buprenorphine. So it's, ACOG guidelines do not recommend this transition right now. So I found one study that did transition 20 patients based on the results from the mother trial, thinking there's a benefit of buprenorphine over methadone. There was no comparison group for this study. Effectiveness and satisfaction with treatment were comparable to other reports, but this is another, not super well designed study to be able to make conclusions about whether or not this should be practiced. Do we transition patients who are stable and happy on their methadone to buprenorphine because of these lower risks of neonatal abstinence syndrome and preterm birth? So I don't think we have enough data to know yet if that makes sense. Because what gestational age do you switch? Does that matter? If you already have exposure to methadone and then you go through this process of switching, do you still get the benefits that we see of buprenorphine? Are there certain patients that are ideal candidates for this and not? So as you can see, these 2 potential mechanisms either means changing how we dose methadone or switching patients from methadone to buprenorphine. They're quite different in what we decide to do. So I think there's still quite a few unanswered questions in how we actually treat patients in this area. So just kind of in conclusion, I think this research supports continued use of buprenorphine as a first-line treatment in pregnancy. And we still need some data to understand if we should be making other choices. But methadone is still an important option in pregnancy. It's still effective for preventing these really terrible outcomes of overdose and death in these pregnant patients, and should still be considered a supported and good option for these treatment in pregnancy. And a lot of the clinicians that were on this paper were really wanted to make sure this point was really clear. It's important to understand the differences between these two drugs, but it's also important that patients have access or patients can use either of these drugs, because which one they have access to also really impacts whether or not they're going to be treated, and any treatment is much better than no treatment. So that's what I have. I'm happy to take questions or any discussion. Let me just stop sharing just so I can see if there are questions in the chat, and I can always pull up my slides again if people had specific questions.
I think Nir is clapping and ready for a comment at the same time. Nir?
Yeah, go ahead.
That was yeah, beautifully presented and impressive research. I have a bunch of questions. One is so some of them are just clarification. So one is there a difference in the price of the two drugs? Difference that is likely to remain in place? So are there issues about cost effectiveness?
That is the question I really can't answer. You know, I'm not sure that, I mean, I don't know. Do you know a little bit more about the policy side of this than I do?
I think Nir that because these are, it wouldn't be a out-of-pocket cost in general for these Medicaid patients, but it's more the sort of the long-standing inequities that exist as to where buprenorphine providers are available, where methadone providers are available. This was Liz was making the point that it may depend a lot on what's available in your place. So, for example, if if a mom enters pregnancy on one of these treatments, all right, then you have the issue of not wanting to switch. Historically, the inner city populations were more heavily treated with methadone, although there's been a lot of efforts in some cities to change that. But I mean, the economics enters in, but I take it, by the way, the long-acting formulations are not recommended because they wouldn't be easy to reverse if necessary. Is that right, Liz?
I think we just don't have any data yet.
Yeah, the long-acting formulations are the ones that are more expensive.
So just maybe a comment on the question whether it's the dosing of methadone or buprenorphine is simply better. I'm wondering if I didn't quite hear you say there should be a study that checks that, but I'm an ethicist. The ethics of this study would be interesting because, if I were a pregnant woman in a candidate, I would probably want to be on the kind of safest arm, which is the drug that can't be found in either dose, kind of to be worse. Basically, not on trying to fiddle with the dosing, and kind of maybe that wouldn't be so bad. So, I don't know if you have any thoughts about the follow-up studies and the ethics of them.
Yeah, that's a fair and good question. I mean, I know one of my collaborators from this study is currently, I think, doing a small trial looking at split dosing. I mean, I think that's kind of the leading theory. That's what a lot of people believe is what's happening. And so she is doing a trial now. I don't know many details of it. It would have been initiated prior to the publication of our paper. But, she was also, part of the mother trial. So I think like the potential benefits of buprenorphine have been known for a while. There are differences potentially in efficacy, and this is an area where I am not as well versed in. But at least from patients, we saw in the mother trial that patients were not as satisfied with buprenorphine. Maybe that was related to dosing that can be fixed. There is concern too when our paper was published. There was an editorial that accompanied it in New England Journal that noted that maybe methadone is going to be a more effective treatment in light of increasing use of fentanyl, which I'm not familiar with whether or not that's strictly true, but that's what this one other clinician in this area included in her editorial of our paper. So I think there's still a lot of reasons. This is kind of just one piece of the puzzle in terms of deciding if buprenorphine is better than methadone overall, which would weigh into it there. I'm trying to think about other retrospective studies we can do, other data that may be out there. It's obviously really hard in the US because split dosing for methadone is just not done routinely. There are other countries where take-home dosing and methadone is administered in other ways. So I don't know if there's potential to see if anyone's doing this kind of split dosing. I'm thinking of I think Australia and the UK and Canada. I haven't looked into it very far other than kind of reading over some guidelines and looking at papers in these populations in these other countries. So
the new SAMHSA guidelines, which are out for comment as a federal regulation, are much more encouraging towards take home. So I think under the new regime, I would certainly think that as a clinical trial, it would not have either regulatory or ethical issues. But of course, unlike Nir, I'm not an ethicist.
It's a fascinating case. Just I'll shut up just after I drop this because I'm in. Some ethicists believe that there should be so-called equipoise between all study arms. They should all have kind of equal prospects for success, something like that. I'm somebody who doesn't believe that. I think we tell people, you want to help us. We make sure that they understand that they might be randomized to an intervention where that would be suboptimal compared to what a clinician would have advised them if it was not a trial context. But do you want to volunteer and take the risk? And there are some benefits to being in the trial. Up to you. The complication here is that the main affected party is the currently fetus future person, and they don't give their consent. So usually the threshold for in these cases is much more protective. So interesting case to think about.
Yeah, and I wonder if an easier, and I don't know this one trial that one of my colleagues has going. I'm not sure. I don't know much about it. I don't know what the design is and what the comparison is and what's being randomized. But perhaps if you have patients that are already well established on methadone, are pregnant, and then you compare split to single dosing within that population, that might be a question that you don't have as much ethical concerns about, as opposed to, first time patients in pregnancy, assigning them to buprenorphine or assigning them to some version of methadone.
Let's encourage everybody else to get your questions in. If you have questions, we'll just take a moment and encourage everybody. We have 4 minutes remaining for questions.
I have one more question if you...
Yes, absolutely.
First, others should... Okay. All right. So going back in your slides, is there a way? So you mentioned that the use of opioids in general increases overall mortality from specific causes of death. Or sorry, I didn't put it the right way. That's exactly what the question is about. Correlates with more death from suicide, do we have any indication that it causes the deaths, or rather, say the underlying cause for the suicide and the use of opioids is something like pain, but the opioid is not the cause of death? If so, one might even think outside the box and say it's a good thing that they're taking opioids because it's a canary in the mine. We know if somebody there's evidence that we need to send their kind of aid to prevent the suicide, which would be caused by something else.
Yeah, so that analysis looked specifically at patients that had diagnoses for opioid use disorder in pregnancy, or they had evidence of buprenorphine or methadone use. So we're not sure about their active use at the time of death. They could be opioid use disorder patients that have it coded. They're not on either treatment, but they're also not actively misusing. So I wouldn't want to jump necessarily to say opioids are potentially causing these causes of death. I think it's more looking at, there's a lot of problems that this population faces in terms of their, maybe the quality of care they're getting, the other complications they have, their mental health issues potentially being exasperated in the postpartum period, which we know already happens with postpartum depression and psychosis. So I think it's probably multifaceted. And I wouldn't conclude that it's specifically something about the opioids. The point of that paper was to kind of say, like, we know they have an increased risk of opioid use or opioid overdose death, but we haven't really looked into their overall mortality, and we can do that on this kind of more national scale with this data. And let's look at all of the other causes of death too, and kind of see how that compares to what we know on a broad scale in pregnancy.
Fantastic. Any last question from anybody? I'm just so impressed with the quality of the study and just the very careful and complete way that you looked at all the potential confounders and use sophisticated methods to try to address them. So I think it's going to be a very influential study, and it will be very interesting to see what the response is, because practice changes slowly, but when decisions have to be made about, you mentioned that switching may not be advisable, but when women are encouraged to start MOED during pregnancy, then there needs to be there has to be a choice. And then what the clinical practice becomes for that choice, it's going to be a very interesting question. So thank you so much for sharing that, and just the it's impressive to see how carefully and well that study was done. So
Thank you so much. Thank you. Thanks for having me.